everyone, and welcome to the first part of CATA's special three-part webinar series, There's Always Evidence. I'm Suzanne McGurran, the President and Chief Executive Officer of CATA. I'm speaking to you from Ottawa, Ontario, Canada, which is on the traditional unceded territory of the Algonquin and Anishinaabe people. I want to acknowledge and thank the generations of people who have taken care of this land for thousands of years. I encourage everyone participating in today's session to think about the land where you are, the people who've been stewards of that land, and our shared responsibility to preserve and protect the land for future generations. Because of the ongoing pandemic, we've become accustomed to virtual gatherings where speakers and participants are separated by geography. On this occasion, however, we're also separated by time. Due to a scheduling conflict, I recorded these introductory remarks yesterday afternoon, although I suppose asynchronous communication is also becoming the norm. I wanted to introduce this webinar series because the topic is fundamental to the understanding of what CATAS does and what other health technology assessment bodies, health management bodies, and health research organizations do, and can't do for that matter. In a recent email exchange I had with Dr. Ronaldo Batista, one of the pioneers in health technology assessment and a recent recipient of the Order of Canada, he noted that COVID-19 pandemic has increased awareness of the crucial links between science and decision making. There were 4 key points that immediately came to mind as a result of his comment. The first is that decisions in healthcare are informed by evidence are likely to be better than decisions based on gut instinct alone. The second is that high quality evidence is not always available. For many drugs, health technologies, and health intervention, definitive answers are not always available when the decision needs to be made. The third is that sometimes decisions need to be made in the absence of high quality evidence. Some interventions cannot be studied using empirical research methods for ethical or practical reasons, which means there are no systematic reviews with meta-analysis or double-blind randomized controlled trials. Some health emergencies, such as the pandemic we're currently experiencing, highlight the requirement for an immediate response and cannot wait for high-quality evidence to become available. My fourth and final point is even in the absence of gold standard evidence, like randomized clinical control trials, there is always evidence that can be used to inform decisions. CADIT and other HTA organizations are in the business of providing and reviewing the best available evidence for decisions. We are not in the business of appraising only the highest quality evidence. In the absence of gold standard evidence, that could mean we are sifting through the research to find observational studies, case studies, and administrative data that can inform a timely decision. HTA bodies can't provide evidence that doesn't exist. We can't snap our fingers and have high quality evidence appear, but if it exists, we will find it. And if it doesn't, we will search for and find the best available evidence, appraise its quality, and provide it to decision makers in a timely fashion and easy to use format. During this special webinar series, you'll learn about a wide range of evidence sources that can be tapped into to inform evidence-based practice and evidence-based policy decisions when gold standard evidence is not readily available. Our distinguished guest speaker today is Dr. Gordon Guyatt, who will outline the key concepts and bring them to life with real-world examples. The series will continue in February with sessions by Dr. Amanda Shepard and Sahir Jamal, and highlight the unique value and benefit of using observational, non-randomized studies to inform healthcare decisions, policy, and practice. Thank you for taking the time to join us today for this kickoff session. I hope you will find it informative, engaging, and useful. Now I'm going to hand things over to today's moderator, Dr. Nicole Mittman, Chief Scientist and Vice President, Evidence Standards at CATA.
Thank you, Suzanne. Thanks for providing the context for today's webinar. And for those of you who may have had some audio issues, we do apologize for that, but certainly this webinar series will cover a number of the points that Suzanne mentioned. And we'll be hosting a number of other webinars that will reach into some of the questions that Suzanne had indicated. So before we get underway, I just thought I wanted to cover a few logistical issues. Certainly this was planned to be a very interactive and informal session, which is a bit of a challenge because we understand that there are 1,200 registrants for this particular webinar series. However, we're going to try and approach things to make it interactive. First, there will be interactive polls throughout the session. Second, we'll be using both the chat function and the Q&A function. You'll find those tabs at the bottom of your Zoom control bar. The chat will be used for discussion, observations, and comments relevant to all participants. The Q&A tab, on the other hand, will be used where you can ask Dr. Guyatt some questions. Third and last, as moderator, I'll be monitoring both the chat and the Q&A with the help of some team members behind the scenes. And Dr. Guyatt has certainly given me strict instructions to interrupt him whenever I see a question or a comment that is particularly pertinent or especially intriguing based on the topic he's presenting. So please don't wait until the end of the session. Use the chat function, use the Q&A session or tab throughout the talk, and I'll do my best to keep up. So now let me introduce our speaker, Dr. Gordon Guyatt. It is my great pleasure to introduce him. Who better to kick off a series or a three-part series entitled "There's Always Evidence" than the man who was inducted in the Canadian Medical Hall of Fame for introducing the term and the concept of evidence-based medicine in a paper in 1991. Dr. Gordon Guyatt is a practicing physician in Hamilton, Ontario, and is a distinguished professor at McMaster University and one of the most cited scientists in the world, with more than 1,000 published papers and more than 150,000 citations. So may I turn it over to you, Dr. Guyatt?
Thanks very much. I'm now going to share my screen, and that takes us to the presentation. So first of all, the way I tend to present is to maximize interactions, which, as Nicole has said, is exceptionally challenging when one is doing a virtual presentation with upwards of heading toward 1,000 people participating. However, we're going to try hard. And we're going to try hard in two ways, where I'm going to pose some yes or no or multiple choice questions, and you're going to have the opportunity to answer those. And please use the chat. And if you have any questions or comments as I go along, I'm going to ask specific questions, and it'd be great if on the chat you responded to those. And in addition to that, if you have a question or a comment as we go along, I welcome interruptions. So there's always evidence beyond traditional evidence-based decision-making. And there we are. Following relevant financial relationships to disclose. Some of you may know about UpToDate, which is the world's most popular electronic textbook. I've been consultant for them for number of years. Non-financial relevant conflicts, co-chair of the GRADE working group. You'll hear more about GRADE. I'm the chief scientific officer of a group called Making GRADE the Irresistible Choice, Magic Evidence Ecosystem Foundation. Here's what we're going to do. I'm going to start with a parody of evidence-based medicine, which will make the point that we need to use the highest quality evidence available, even if that is not high quality evidence. I'm going to talk about the GRADE system, about which I'm very conflicted and have a strong belief in its usefulness. The heart of the presentation is to focus you on indirect evidence, so that when you don't have randomized trials, you may turn to observational studies, but there may also be indirect evidence differing from your PICO that may inform decisions. The example that I'm going to use from a previous CADITH assignment was the use of thrombolysis in patients with myocardial infarctions in remote settings, and in particular, the use of indirect evidence there. And again, welcome questions, comments, interruptions throughout. So here is a parody of evidence-based medicine in the clinical context. The patient presents with some kind of awful pain. The doctor turns to the computer, click, 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 turns back to the patient and says, "Sorry, I couldn't find any randomized trials. I can't help you." That is obviously not the way we want to practice medicine. The doctor who can't find randomized trials must look to the best available evidence to help the patient. We think the same applies to health policy. If a client comes to you for assistance with a health policy issue, you cannot say, "Sorry, no randomized trials, can't help you." The true use of evidence-based medicine, either in the clinical or health policy realm, is to use the best available evidence. Even it may turn out to be low or very low quality, but if it's the best, you need to use it to inform your decisions. So I'm going to turn now to the grade approach to summarizing evidence and making recommendations. It is, as you'll see, very widely used, giving me some confidence in spending some time talking to you about that. The grade group started to meet in the year 2000, and the first paper describing the approach appeared in the British Medical Journal in 2004. Guidance for clinicians to understand the grade approach, these were consumers of grade, primarily clinicians, at least at that time, and a 6-part series appeared in the British Medical Journal in 2008. We have generally been very happy with the uptake of grade. Over 110 organizations worldwide are now using approach. Some very prominent ones like the World Health Organization or the National Health Service and their National Institute for Clinical Excellence, or NICE. Major American groups like the American Thoracic Society and the American College of Physicians. I've already mentioned the group with which I'm conflicted, the leading electronic textbook for clinicians, which is up to date, which has over 1,000 graded recommendations. One of the most prominent HTA organizations in the world, the Swedish SBU, American Center for Disease Control, and so on. So very wide uptake of the grade approach. Wherever you work, you might be seeing it in various contexts. So what are we grading when we use grade? Excuse me. 2 components. One has at least 3 synonyms: the quality of the evidence, which is synonym, our confidence in the evidence, which is another synonym, our certainty in the evidence. And you will, if you look at grade writings, you will see all 3 of them used. Conceptually, there is a continuum between no confidence at all at the one end and total confidence at the other end. We're seldom at the far extremes, but it can be anywhere in this continuum, and grade has decided to turn this continuum into categories. And the categories are very low, low, moderate, and high quality or high certainty of evidence. Grade also takes you from the evidence to the recommendations and suggests an approach for making that transition. Only 2, a binary characterization of strength of recommendations, strong and weak. Many guideline panels don't like to call their recommendations weak. And so, for instance, contingent or conditional recommendations is what they will offer, but that again is synonymous with weak. This presentation focuses on the top part of this slide, that is the quality, confidence, or certainty of the evidence. And that, for instance, is what CABIT does, is its business to summarize the evidence for the folks who ultimately will be making recommendations or taking clinical or health policy action. So how does this certainty or quality of evidence work? Randomized trials start as high quality evidence. Observational studies start as low quality evidence. So picture you have 10 relevant randomized trials addressing a particular question. Looks good, 10 randomized trials, we're going to have high quality evidence, right? Well, maybe not. I would like you all to think now, what can lower the quality, confidence, or certainty of evidence, even if you have 10 randomized trials? Now, here is the first test of whether the interaction approach is going to work under these challenging circumstances. I would like anyone who has a suggestion of why 10 randomized trials might not yield high quality evidence to go on to the chat and make your suggestion. And Nicole and colleagues, you're going to watch the chat, and if somebody has a suggestion, if you could bring it to our attention, that would be great. So strong encouragement, folks, to make your suggestions.
So Gordon, I'm just reading the chat function and it's blowing up a little bit, which is fantastic. So that means our interaction is working. A couple of the comments that I'm seeing over and over
One
again.
at a time, please, Nicole.
Okay, so if we do one at a time, one of them was bias.
Right, okay, excellent. So randomized trials can be well done or they can be poorly done. So they may be blinded, concealed, and have 100% follow-up, or they may be unblinded, unconcealed, and lose half their patients to follow-up. If these 10 randomized trials are poorly done and poorly executed, poorly planned, poorly executed, we have risk of bias problems. And one of the reasons for, in the grade approach, rating down the quality of evidence from randomized trials will be risk of bias. Excellent. Okay. Another suggestion, Nicole.
Small sample size.
Excellent. Okay. So small sample size leads to, they may be 10 trials, which all enrolled only 20 patients. And in the end, you only have 200. So that small sample size leads to wide confidence intervals. Wide confidence intervals decrease our certainty. So using the grade terminology, we have not only risk of bias as a reason for rating down, but we also have imprecision reflected in small sample size and wide confidence intervals. Excellent. So we have two, you've identified already two of the major categories for rating down the quality or certainty of evidence that grade suggests. Is there another one that someone has suggested, Nicole?
Sure, there are a few other ones, and this one I'll put into maybe a composite outcome of representativeness of the population, eligibility criteria of the cohort included in the study.
Right, okay. So this will become vividly evident later in the presentation. As a matter of fact, it may be the core of this presentation is the issue of what grade calls indirectness. So I think what that question focused on is indirectness of the patients or population. So for instance, if we're talking about a clinical situation, I practice general internal medicine, hospital-based, and I try to base my practice on randomized trials. However, over the last decade, increasingly so, some of my patients are old and what you might call very old. Quite a number now are over 90. I have some doubts about applying the results of randomized trials to my patients over 90 to those who were in the randomized trials, probably very few or none of whom might have been over 90 or even over 80. So that's a situation of indirectness with respect to the population in a clinical setting. We will see later on in this presentation about indirectness of the population in a health policy setting. So now, great, we've identified 3 reasons where randomized trials may not yield high quality evidence: risk of bias, small sample size, and which Grade refers to as imprecision, and indirectness of the population. This is going very well. Next suggestion, Nicole.
There have been a couple of comments about the outcome specifically, and perhaps either a poorly defined primary endpoint or not relevant to a clinical outcome.
Okay, so another source of indirectness, we've mentioned indirectness of the population. You can have indirectness of the outcome. So clinicians are often fond of considering giving a therapy because it improves bone density or because it lowers your glucose in people with diabetes. Those are what we call surrogate outcomes. And what we're really interested in is not bone density, but fractures. What we are really interested in is not lowering your blood glucose, but preventing the micro and macrovascular complications of diabetes. So you have indirectness of patients, indirectness of outcomes as well. And we've also mentioned thus far risk of bias and imprecision. Next, Nicole.
There are a couple of comments around confounding or confounders.
Okay, so my understanding of confounding is that prognostic variables, age, sex, and so on, are differentially represented in the intervention and the control group. So if your intervention group is much younger than your control group, since age is very frequently a prognostic factor, it is confounding the comparison. Absolutely right. And in the Grade terminology, that's one of the risk of bias issues that randomization is designed to deal with, and in observational studies, adjusted analysis is designed to deal with. So once again, we've reinforced our risk of bias as a reason for rating down. We've identified imprecision and indirectness of both patients and outcomes. Next, Nicole.
So there have been a couple of comments around funding.
Very interesting, okay? So to what extent is funding a problem? Let us say a drug company has funded a particular trial, and you look at it carefully and you found the randomization was very well done. Randomization was concealed. Patients, caregivers, those adjudicating outcomes, those collecting data were all blinded, and they had 100% follow-up. Do we have a problem? Grade would argue we do not, in terms of the quality of the evidence. However, Grade would also point out that we often have a problem in interpretation of the evidence. So there are many well-done studies that have a distorted, misleading, present interpretation of the results. And that's where we worry. So in terms of risk of bias, we have our criteria. If they're followed, we're not worried about that. However, funders very often give distorted interpretations of the results, make interpretations that make the intervention look much better than it really is. We believe that a careful look at the study methodology will highlight what the appropriate interpretation would be. Next.
All right, we have blinding.
Okay, so blinding is right. Grade puts that under risk of bias. I mentioned that randomized trials might be limited because they are unconcealed, unblinded, or lose lots of patients to follow up. Those are 3 major reasons grade puts that under risk of bias. Next.
Comparators.
Okay, excellent. Okay, so let's say the comparator is standard of care. Well, if you are in the northern, far north of Canada, the standard of care might be different than if you're at a tertiary care hospital in downtown Toronto. And depending on, you have a trial in one setting or the other, and you're trying to apply it to the other, bit of a problem. That's another issue of indirectness. So you can have indirectness of the patients. As it turns out, you can have indirectness of the intervention, indirectness of the comparator, and indirectness of the outcome. So lots of indirectness that we might be concerned about. So we've identified concealment, blinding, loss to follow-up as risk of bias issues. We've identified small sample sizes, imprecision issues, and we've identified now a whole number of indirectness issues of patients, interventions, comparators, and outcomes. One more, Nicole, and then probably should move on.
Thanks. And I was about to say that most of them are along the same lines as we've already discussed, but the last one that we haven't yet discussed are issues around compliance or adherence.
All right. Okay. So we may be interested in, our patients may be interested, and some of us would argue that they are mostly interested in what's going to happen if they take the medication. And now you have a trial where only 70% of the people took the medication. Doctor says, patient says, what benefit I'm going to get? Doctor says, well, I can tell you what benefit people get when 70% of the patients take the medication. Patient says, well, but I want to know the benefit when I would take it. Grade puts that again under an issue of indirectness. The patient is interested, ideally would like to see what happens when everybody takes it. What's available is what happens when 70% of people take it, and that's indirect evidence. So you have done very well. You've identified the risk of bias issues, including lack of blinding and loss to follow-up, imprecision issues that go with small sample size, indirectness issues, which is a major theme of this presentation, which can be indirectness of the patient's interventions, comparators of the outcomes. There are two others that you didn't identify: inconsistency. If the results are different across trials and we can't explain the difference, that could be a problem, and publication bias. Okay, that was excellent. So thanks everybody for making the interactive aspects of this work very well. So I'm going to discuss one of the reasons for rating down specifically to give you more insight into the grade approach, and that's the small sample size and small number of events. And that is then reflected in wide confidence intervals. If the confidence intervals are wide, we have uncertainty about the magnitude of effect. Now, here is a challenge. Does anybody in the chat want to offer a suggestion of how we decide when is a confidence interval too wide? When do we need to rate down, thinking of grade, for imprecision because the confidence interval is too wide? Anybody have a suggestion?
I'm just monitoring the chat function, Gordon.
Yeah, this is a tougher question than the previous. Okay.
Couple of questions are, it depends on the outcome, when it crosses the 0 mark, crossing the 0, crossing the 0, crossing the 0.
Okay, picture a confidence interval where the relative risk is from 0.99 to 1.01. Okay, that crosses no difference. Do you want to rate down for imprecision? Don't think so. In other words, we can have an extremely narrow confidence interval that borders on either side of no difference. So one can have a precise estimate of no effect. Sometimes our treatments, unfortunately, have no effect. And if we have a very large sample size with a point estimate close to 0, very narrow confidence interval around it, we will not be rating down for imprecision. So that's an intuitive answer that many people provide, but it doesn't work because one can have a precise estimate of a 0 or near 0 effect. Crosses the line of no difference, but we're in good shape because we have a precise estimate of a 0 or non-zero effect. Any other suggestion that comes up, Nicole?
A couple of them are around making sure you're defining the threshold or considering the clinical relevant or clinically relevant effect.
Great. And that is what GRADE perceives to be the right answer to the question. Great, which I will try to illustrate. Atrial fibrillation is an abnormal heartbeat, irregular heartbeat that increases the risk of stroke. Anticoagulants are offered as treatments to reduce the risk of stroke. I'll give some hypothetical numbers. Anticoagulants, colloquially called often blood thinners, increase the risk of serious gastrointestinal bleeding. Gastrointestinal bleeding, you wake up one day, you feel terrible, you suddenly vomit large amounts of blood, you feel terrified, you go to the emergency, the doctors put a tube down and they correct the situation. And a few days later, you're out of hospital and you're probably not taking anticoagulants anymore. Now, that's a description of a serious gastrointestinal bleed. Let's say we give these anticoagulants to 1,000 patients with atrial fibrillation and we prevent 1 stroke. In other words, we are causing 30 bleeds with our anticoagulants in 1,000 people and preventing 1 stroke. Who would think anticoagulants are a good idea under these circumstances? So here's a vote. Here's the first of our votes. Yes, say yes if you think it's a good idea under these circumstances. Say no if you think that the deal is not very good if you're causing 30 bleeds to prevent only 1 stroke in 1,000 people. So yes or no. Now, have we given people instructions of how to vote, Nicole? I don't see any.
So thanks very much. And so you have an option in front of you. You should have a box that's popped up and you can vote there. We will show the results afterwards. And once the poll is finished, you actually have to close the box. Okay, and we'll wait for, here we are.
Aha, excellent. Okay, so there are some very stroke averse people who think that preventing once, and they're not very too worried about gastrointestinal bleeds, and they think that even preventing 1 stroke is all right, even though you're causing 30 bleeds, that might be worth it, but the majority do not. Now, second situation, in the 1,000 patients, you're preventing 100 strokes. So now you're preventing 3 strokes for each bleed. How many think that anticoagulants would be a good idea under these circumstances?
Okay, it looks like people are entering in their results and we'll have something pop up.
Okay, great. Almost everybody thinks it's a good idea under these circumstances. Okay, so at least for the majority, 1 was not enough, given that you're causing 30 bleeds, 100 was plenty. That suggests there's a threshold. Somewhere between 1 and 100, we cross between we're not getting enough stroke benefit to we're getting enough stroke benefit. So where is your threshold? how many strokes in 100 patients with 3% bleeding would we need? Well, as it turns out, people have actually studied this question and they've asked patients. And a reasonable summary estimate of what they found is that the average or typical patients thinks a stroke is 3 times worse than a bleed. In other words, when you're causing 30 bleeds, you want to prevent at least 10 strokes to make it worthwhile. So let's say that is the threshold, a 1% absolute risk reduction in strokes. Given that we have a 3% bleeding risk, it makes it worthwhile to use the anticoagulant. Here is a point estimate and confidence interval from a systematic review and meta-analysis. Is the confidence interval narrow enough? Who says yes? Who says no?
Okay. We'll look for the results again.
Okay, it splits. The majority say yes, some say no. According to grade reasoning, those who said yes have got it right. Why? Because if the point estimate is the truth, it is greater than our threshold and we should be using the anticoagulants. But that is also true for both ends of the confidence interval, both for the upper end and the lower end. The entire confidence interval is above our threshold, suggesting that the results are sufficiently precise. And at least as far as precision is concerned, we can encourage our patients to use anticoagulants. What about this one? Sufficiently precise, yes or no? Should we be rating down in the grade framework for imprecision?
Okay, looks like we have more individuals answering this one. And for the results?
That's okay. So the majority have the right answer. Here, it is not sufficiently precise because if the point estimate or the upper boundary were the truth, we should be encouraging patients to use anticoagulants. But if the lower boundary of the confidence interval were the truth, we probably should not be encouraging them to use it. So we have imprecision has introduced substantial uncertainty. What about, whoops, there we go. What about this point estimate and confidence interval? Is that sufficiently narrow? Yes or no?
Okay. I see folks are entering. And the results are, I feel like I need to do a drum roll.
Splits 50-50. Interesting. Okay. Well, this is almost as close as the American election. Okay, 53 and 47. As it turns out, the 53, we got it right. Perhaps as some of us think they did at the American election. So as it turns out, whether the point estimate is true or this end of the confidence interval is true or this end of the confidence interval is true, we're not preventing enough strokes to compensate for our bleeding. We're all on one side of our threshold of an important benefit, and as a result, the confidence interval is sufficiently narrow. What about, having some problems here changing my slides, what about this one? Narrow enough or not narrow enough?
I think we have another yes or no poll.
That's right, yes or no. Narrow enough or not?
Okay, and the results?
Almost everybody says no, and almost or most, and you are right. Because if this were the truth, It's actually harmful, more strokes, no good. Point estimate is true. We have some benefit, but it's less than our threshold, isn't worth compensating for the bleeds. At the this end of the confidence interval, if this were the truth, we'd be preventing enough strokes to compensate for the bleeds. And as a result, we would we have a problem with imprecision. And so what's the bottom line of this? The bottom line is the grade guidance for imprecision is rate down if it crosses a decision threshold. Don't rate down if it doesn't cross. Here and here it did not cross. Here and here it crossed our decision threshold.
So Gordon, just before you go on, can you just repeat that? And then just because I saw that the arrow was not going exactly where it should have gone.
Thank you very much, Nicole. I welcome feedback like that. We rate down, bottom line for grade, we rate down if the confidence interval crosses a decision threshold. We don't if it doesn't. This one, it doesn't cross our decision threshold at one end. This one, it doesn't cross our decision threshold. We won't rate down for imprecision. This one, it crosses our decision threshold. This one, it crosses our decision threshold. And as a result, we need to rate down for imprecision.
Perfect. Thank you. Can I just add a couple of other comments? I'm watching the chat function.
Please.
For some very insightful folks who are also asking around, well, we haven't included severity of the stroke in our consideration, and these are outside of what you've talked about around precision. We haven't thought about the economics, and we haven't heard from the patient. So I just wanted to highlight those other comments that are happening in the chat function.
Great, superb, and these are all relevant to where you set your threshold, okay? And I was obviously simplifying it. You said we haven't heard from the patients. I did mention in one sentence, easy to miss, that there have been some studies of what patients think about this that suggest that that 1% threshold, stroke is 3 times worse than bleeds, may be what the average patient thinks. So, but great points, all relevant to where we set our threshold. Excellent points.
And then maybe the last one is around who should decide the decision threshold.
The grade has a very clear guidance on this. The people for whom the recommendation is intended. So in this case, people with atrial fibrillation at risk of stroke should be the ones to decide on the decision threshold. Okay. Here's a summary now of grade's approach, what we have been through. Randomized trials start as high quality or certainty of evidence, but we may lower the certainty with risk of bias, inconsistency, indirectness, imprecision, or publication bias. Observational studies start as low quality evidence. The main reason we might grade up is for a large or very large effect. So that is the grade approach. If anybody of you on this call seems, this might be appealing, it's been widely used, perhaps it makes sense for systematic, it can be used for systematic reviews, health technology assessment, or for guideline developers. There is a 30-part series in a methods journal, the Journal of Clinical Epidemiology, started in 2011, continues, I should have had 2021 here, but the key articles for CADITH or for anybody else, as far as I'm concerned, Article 3 in this series summarizes the quality of evidence issues we've just been through. Articles 4 to 8 focus on risk of bias, publication bias, imprecision, inconsistency, and indirectness. Article 9 is about rating up the quality of the evidence, most commonly because of large effects. Grade does consider cost in Article 10. Article 11 gives the overall confidence, and 12 and 13 talk about summary of findings tables. And very shortly, you're going to hear about grade summary of findings tables. So, I'm now going to move to a new topic, perhaps the heart of this presentation, which is finding the best quality evidence even though that best quality evidence is not such high quality. And one way of considering this issue is the PICO, the patient's intervention comparator and outcome of interest, versus eligibility, excuse me, versus eligibility criteria for our systematic review. So we recently addressed patients with COVID-19, either patients with acute respiratory distress, adult respiratory distress syndrome, an inflammatory condition of the lung, which is often fatal, and another population with severe COVID, but not critical. In other words, not bad enough to have ARDS. Our intervention was corticosteroids plus supportive care. Our comparator was supportive care with no corticosteroids. Our outcomes include mortality, duration of hospitalization, and the complications of steroids. Now, what studies would you like to address this question? Ideally, we'd have randomized trials comparing steroids to no corticosteroids, some for the ARDS population, some for the severe but not critical. But we expected a yield of 0. Now, given that we expect a yield of 0, would you also want to include observational studies comparing corticosteroids to no corticosteroids? There's a poll for that, yes or no.
Okay, we see people are answering the poll. Okay, can we see the results, please?
And almost everybody says yes, we would agree with that. Unfortunately, we expected only very low quality evidence from the observational studies. Okay, this was early on. We were doing this when COVID was restricted to China back in March. And so at that time, not only were we going to have no randomized trials, but we expected that our observational studies would be only very low quality. Given that, for the ARDS population, would you include randomized trials of observational studies in people without COVID, but with ARDS? Yes or no?
Okay, you should see the poll on your screen. And let's have the results.
Most people say yes, although some no. So this is an issue of how much indirectness we are ready to tolerate. The ARDS in the non-COVID provide indirect evidence for ARDS in COVID. We thought worth including. Now let's move to the non-ARDS population. RCTs or observational studies in other coronaviruses, SARS or MERS. Is it relevant? Should we include observational studies for different viruses that are, but they are coronaviruses? Yes or no? Steroids, so they have studies in SARS and MERS, steroids versus no steroids, eligible or not eligible? And most people say yes, and we would agree with that. What about RCTs and observational studies in a non-coronavirus, influenza? So patients with influenza who did or did not receive steroids. Should those be eligible? And most people say no. And I might be inclined to agree. We debated that ourselves. You can easily make a case that that's too indirect. However, we included it, as you will see.
Gordon, can I ask a question that's come up in the chat function?
Sure.
So one of the questions is, would you also include preclinical studies if no other indirect clinical studies are there to support the analysis?
The answer is yes. If that's all you had, then you would go. We always use the highest quality evidence available. And if you had nothing clinical, then you would go to preclinical studies. You would hope, and here again, at a certain point, most people said, if we have these other evidence, we're not going to include influenza. If we had none of this, we might include influenza. So it's always the highest quality evidence available.
Thank you.
All right. So here's what the evidence showed when we did this. Here's a summary of findings tables for COVID and ARDS. Only one study with 84 patients with a big apparent reduction in deaths in people who receive steroids, more than 50% reduction in hazard. But it's only observational studies, start as low quality evidence, very wide confidence interval. We rate down for imprecision, a plain language summary. We're very uncertain of the effect of corticosteroids on mortality. This is a grade summary of findings tables. It lists the outcome, the relative effects, the control group risk, the difference with treatment in those who receive treatment, the quality or certainty of the evidence, and a plain language summary of what you see in the other columns. Here is a summary of the randomized trials of ARDS, but not the COVID population. Mortality, a 72% relative risk reduction. Baseline risk for the control group. We took this from the COVID patients, what might happen to them. The benefit was a 17% reduction in mortality, lower boundary of the confidence interval, 4.3%, which we said patients would still consider that important. The only thing, so this was high quality evidence in the non-COVID setting, but we called it only low quality of evidence in the COVID setting because we rated down 2 for indirectness. So we said corticosteroids may result, low quality evidence, we say it may result in a large reduction in mortality. We had mostly low or very low quality evidence for other outcomes, length of ICU stay, length of hospitalization, duration of mechanical ventilation. Serious hypoglycemia, the negative consequences may be of interest. A confidence interval increase in serious hypoglycemia from 1.01 to 1.24. Here we call low quality evidence. Here we only rated down 1 for indirectness because we thought there's no reason we can think of, or difficult to think of a reason why if steroids increase your blood glucose, why that shouldn't happen in people with ARDS secondary to COVID and serious imprecision with a confidence interval that almost overlaps no effect. Low quality evidence of serious hypoglycemia. Corticosteroids may increase serious hyperglycemic events. So here is what this indirect evidence shows. And our panel was thought this might be enough to actually, we made a weak recommendation in favor of corticosteroids in this particular group. Now let's move to severe COVID, but no ARDS. With respect to mortality, we had 2 observational studies, 300 patients. Unfortunately, the suggestion was, if anything, harm, but very low observational with serious imprecision, very uncertain. And we had evidence of indirect evidence from SARS. Indirect evidence from SARS, 6,000 patients in 2 observational studies, suggestion of a difference, but serious indirectness and serious imprecision. Here, indirect evidence from MERS, parent benefit, but wide confidence interval, very low quality evidence, uncertain. And we also looked at influenza You folks thought we shouldn't have bothered with that, and maybe we shouldn't have. The bottom line, you see, is at that point in March or April, that's all we had, but people had to decide, should I use steroids or not? So it was the indirect evidence that led our panel to recommend in favor of steroids, weak recommendation in patients with ARDS, but against in the severe but non-ARDS patients. Here is another example of use of indirect evidence and how indirect evidence, what this one shows, can be higher quality than direct evidence. Here's the choice. Patients with end-stage renal disease who have aortic stenosis. You have to replace their aortic valve. You use a bioprosthetic or a mechanical valve. The difference here is bioprosthetic. You don't have to use anticoagulants. The mechanical you do, but the mechanical may be worth it because it lasts longer. And observational studies with all they have available, they had problems, very low quality direct evidence for mortality and for gastrointestinal bleeding. But you would expect that the bleeding, we thought, that the bleeding that you get from use of warfarin will be similar in patients with bioprosthetic valves and in all sorts of other situations when you give warfarin. So we looked at the randomized trials of warfarin versus placebo. We thought we had high quality evidence from the trials. We rated it down just 1 for indirectness. So for that outcome, we actually have higher quality evidence, indirect evidence, than the direct evidence, which was only observational with the studies weren't great. So here's a situation that illustrates that indirect evidence may actually be higher quality than direct evidence. So I will now move to the next part of this presentation, which is patients, the problem presented to CADA. Patients in remote location present to community health center or a medical outpost with an acute myocardial infarction with ST elevation. Thrombolysis is indicated in such patients, and you can give it in the outpost where the patient presents. You could give thrombolysis, or you could wait for transfer to a larger center such as Yellowknife, 2 to 6 hours to get there. Question is, should thrombolysis be given immediately or wait? And that was the question presented to CADA. So our PICO patients in a remote setting with acute ST elevation myocardial infarction, intervention immediate thrombolysis, comparator thrombolysis after transfer to the rural hospital. Outcomes, death, reinfarction, length of hospital stay, subsequent heart failure, okay? We would love to see randomized trials of immediate versus delayed in remote settings. What is our likelihood of finding such trials, high or low? And I think we have a poll for high or low. And as a matter of fact,
4 options.
high, moderate, low, or very low. So what's the probability we're going to find randomized trials in remote settings of giving the thrombolysis immediately or waiting for transfer? What's the likelihood we're going to find such trials? Okay, and the majority of people say, almost everybody says low or very low. And indeed, you are right, there aren't any. So given that there aren't any randomized trials, as it turns out, should we include observational studies of immediate or delayed in remote settings? Yes or no? So now it's still direct, but lower, poorer study design. And almost everybody says yes, and we would agree. Unfortunately, there aren't any of these either. So given there aren't any of these, what about randomized trials in the pre-hospital setting, but versus waiting to the hospital? In other words, you give it at the site or as soon as you get the person in the ambulance, versus hospital, but it's in urban settings. It's not in a remote setting. So should we include these? Yes or no? Now we have a nice study design, but now we're introducing indirectness. So should we include those? And almost everybody says yes, we agree. What about randomized trials of thrombolysis versus no thrombolysis, and particularly if they have a subgroup analysis related to the timing? So if the person presents right away, what's the benefit from thrombolysis? If the person presents later, what's the likelihood of the effect of thrombolysis? Would you include those? And everybody says yes, and we agree. So you're very much getting the idea of that we're interested in indirectness. What about observational studies of the complications in the first hours after thrombolysis, which the people in the remote settings may have to deal with? Would that be relevant evidence? And almost everybody says yes. So you're all getting the idea, the major theme, you're all getting the central theme of this talk, which is when you don't have direct evidence, you look for increasingly indirect evidence that may yet bear on the decision. So
Gordon, I've just had a couple comments in the chat function.
please.
One is around, should we choose an observational study before an RCT with indirect evidence or the opposite?
It depends. So if I understand it, you have an RCT with indirect evidence and an observational study with direct, okay? So the issue is you're likely going to have only low quality evidence from the observational study. What are you going to get from the RCT? It depends on indirectness. So it depends on the circumstances. So this is a good example. We had an observational study of gastrointestinal bleeding with warfarin in the setting of end-stage renal disease and people getting an aortic valve replacement. It started low, it had problems in their design and execution, so it was only very low. Whereas we only decided to rate down 1 for indirectness. It started as high quality and ended up moderate. So here we use the indirect evidence from the randomized trials, had higher quality evidence than the observational study. But it might work out the opposite. Maybe the randomized trials, you would rate down 2 for indirectness, it's very indirect, and you have problems in the design or imprecision or something, and it only ends up as very low quality evidence. So it depends on the circumstances. And the great approach is look at the evidence from the observational studies that are direct, look at the quality of the evidence from the randomized trials that are indirect, and use the higher quality evidence. And that will depend on the circumstances. Sometimes the observational studies probably low, but the randomized trials, because of indirectness and other problems, might be very low. Or maybe the randomized trials aren't so indirect, as in this situation, they give more moderate quality, and you would choose them over the observational studies. Okay? All right. So we were there. Okay, so here's one of these. One source of evidence was pre-hospital versus hospital-initiated thrombolytic therapy. Randomized trial conducted in Seattle, Washington, 175 patients given the thrombolysis at the site when the paramedics got to them, 185 in the hospital, aspirin and alteplase initiated by the paramedics, symptom onset to treatment 92 minutes, plus or minus 58, median 77 in the individuals given immediately versus 102 minutes with a median of 110 in those who waited. Difference in medians, 23 minutes. No difference in mortality, infarct size, or complications. Now a question. Given this design, this trial had a good chance that the treatment would show a difference. Well, it's very unlikely because you wouldn't think that a difference of 23 minutes would be enough to show a difference. Agree or disagree?
Okay, we have the poll up. And maybe if we could close the poll. Thank you.
Splits 50-50. I would think we're in the remote setting, we're looking at a 2 to 6 hour difference. 23 minutes is likely not to be enough. What about, it's very unlikely because of the small sample size, 175 and 185 to make a difference. So very unlikely. So a poll, very unlikely to make a difference because of the small sample size.
Oh, there we go. Perfect, thank you. And maybe the results?
Again, it splits. Okay. The randomized trials that showed any benefit from thrombolysis, and you'll see that in a minute, before we knew that their thrombolysis made any difference versus no thrombolysis, it required thousands of patients. So we were thinking this was destined to show no difference, not enough difference in duration of time, not enough sample size. And that was also true of the other two studies. I'm going to move along a little more quickly. Here's our summary of findings tables for these three studies of previous pre-hospital versus in-hospital. So what about mortality? Seems a little low pre-hospital, but the extremely wide confidence interval from reduction in mortality by 2/3 to a 40% increase. Low quality evidence. This is not for our remote setting. This is not considering indirectness. So the authors think low quality evidence, adverse effects. The only one for bleeding complications was moderate. You could argue still very serious problems with imprecision, low quality. And that's before you consider the indirectness, right? That's just for the urban setting. So how much, so now we're going to try and apply this to our remote setting. How much farther ahead does this evidence lead us in advising our client? Much farther ahead, moderately, little, very little, or not at all. How much does this help us in advising our client who says, in my remote setting, should I give thrombolysis right away or should I wait? Okay, little, very little, or not at all. Somebody says moderate, okay. I would argue, if it were up to me, it'd be a tough choice between very little and not at all. The reason is, it's only low quality evidence if you ignore the indirectness, but it was 23 minutes difference, and we're talking about 2 to 6 hours. That struck me as very indirect. I'd even be inclined to write down 2 for indirectness. And so we're clearly very low quality evidence. My way of looking at it anyway doesn't help us much. So what can we go? Well, so why we're no farther ahead or very little farther ahead. Confidence intervals extremely wide, delay between thrombolysis and hospital much shorter. Setting is also different. I haven't mentioned that yet. Training of personnel, ambulance versus community. So very low quality certainty. I'm going to, because everybody's been so great in offering suggestions and it's been very interactive, I don't have as much time for this slide as I otherwise might have taken. It's a cumulative meta-analysis of thrombolytic therapy after myocardial infarction. And what it shows is a 25% reduction in the odds of dying with thrombolytic therapy in ST elevation myocardial infarction. Now, the other thing I use this slide for, this is cumulative, right? These are not the individual studies. These are adding up as you go down. And as a result, the confidence interval gets narrower, 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 narrower. Confidence interval might have been narrow enough at 6,000 patients, but they randomized another 40,000 patients after the answer was in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. Why'd they have to randomize another 40,000 patients after the answer was in? On this slide, you have expert recommendations that were being made while these data were accumulating. What you see here is big differences in the recommendations, and it's a decade after the answer is in that you finally see a consensus. I use this slide to illustrate the high desirability of systematic reviews and meta-analysis. 1990, when this ended, was just when systematic reviews and meta-analysis were starting to be used. If these experts had had these point estimates and confidence intervals available to them at an earlier point, I think they would have come to consensus a lot earlier. But the bottom line is, with thrombolytic therapy, in relative terms, we get a 25% reduction. But does it matter how quickly after your onset of symptoms you will receive your thrombolysis? Answer is likely yes. This was data from 22 randomized trials of thrombolytic therapy with over 50,000 patients. And what you can see is if you got there in your first hour, you have a big difference between thrombolysis and no thrombolysis, a lot lower mortality in thrombolysis. The longer you wait, the less the difference. Another way of expressing that, proportional reduction. If you get there within 2 hours, 44% odds reduction. If you're more than 2 hours, only 20%. And here is a finer. First hour, you're up around a 50%. 1 to 2 hours, you're between 35 and 40. 2 to 3 hours, you're now at 20%, and it goes down 12 to 24 hours. Not sure there's a benefit at all. So the quicker you get your thrombolysis, the bigger the apparent effect. Okay, so we can now apply this to our rural setting. We can say, what's going to happen in mortality if it's given right away in the rural, in the remote setting, or you're waiting till they get to Yellowknife before you give the thrombolysis. So the absolute benefit is what we're interested. Guess in terms of mortality, 10%. Now, I did quite a bit of work preparing this, but I wasn't as meticulous as I could have been. I, for instance, didn't say I could have looked for data about mortality in the far north on people with myocardial infarction and used that as the baseline risk. I didn't. But I'm guessing it might be around 10%. Well, what about early arrival, immediate thrombolysis? We're going to get a 40% relative risk reduction. You apply that 40% relative risk reduction to the 10% baseline risk, you get a 4% absolute risk reduction. 2 hour delay. The relative risk reduction drops to 30%. You now have a 30%. You've lost 1% by waiting 2 hours. And Sean Secord told me that the delay with the transfer may be anywhere from 2 to 6. If you're lucky enough that it's only 2, you only lose 1% of your benefit. If it's a 6-hour delay and they get thrombolysis on arrival in Yellowknife, the relative risk reduction drops to 20%. That's an absolute of 2%. Now you've lost 2% of your benefit. Okay, so data not available. We've just looked at mortality, but there may be some benefit on recurrent MI or subsequent heart failure. But let's focus on mortality. We get if it's 2 hours, giving it right away, and if they get there and giving it right away versus 2 hours, we gain a 1% absolute risk reduction in mortality. If they have to wait 6 hours, giving it right away to waiting 6 hours, we get a 2% absolute risk reduction in mortality. Just considering mortality, giving it right away, we're going to get a 1 to 2% absolute risk reduction in deaths. Is it worth giving early thrombolysis or not? What do you think? Poll. We're going to get a 1% or 2% is our best estimate of our absolute risk reduction in mortality. Worth it giving thrombolysis or not? Okay, most say yes. Okay, good. So value judgment. Okay, now, are there any other considerations? Is the answer in? We're getting a 1 to 2% benefit in mortality. Answer is in or answer isn't in. What other considerations might be relevant? This is for the chat.
All right, I'm watching. Okay, so far I can see, Gordon, adverse events or side effects. You want just a laundry list or one at a time?
It's okay. We need to move along.
I agree. Okay, so we have cost, likelihood of further delay, more adverse events, knowledge or clinical acumen, management of complications, patient values, comorbidity.
All great. Here's what I thought before I looked at the evidence. Maybe their diagnosis isn't as good, and you're getting people who don't have ST elevation myocardial infarction who are getting the thrombolysis and get the harm by no benefit. Well, this stuff is weight-based. Maybe they're going to make some mistakes. Maybe not. Suboptimal management of perfusion-induced arrhythmias, suboptimal management of bleeding. That's what I thought. But then I found a study. It looked hard for this, no systematic reviews, clinical risks of thrombolytic therapy. First, remember that mortality benefit of 1 to 2% includes all the complications, right? That 1 to 2 benefit is, if the complications kill you, that's included in the 1 to 2% benefit. So the issue here is incremental complications with transport. The complications you're going to get anyway are built in. Intracranial bleeding, 2 to 6 per thousand. What can be done in a tertiary care setting that can't be done in remote for intracranial bleeding? Not much is my assessment. So maybe that's not an issue. Systemic bleeding, highly related to catheterization. You're not catheterizing in the remote. That's not a problem. Serious where site might make a difference, where bleeding might be managed better in Yellowknife than it would peripherally, is under 1%. Reperfusion arrhythmias tend to not be an issue at all. Less ventricular fibrillation, there's less arrhythmias with reperfusion than no. So in the remote setting and transfer, they're actually going to be faced with more arrhythmias if they don't thrombolyze than if they do. Okay, mortality benefit, 1 to 2%, 2-hour delay, 2% is 6 hours. What do you think the quality of the evidence is for that? High, moderate, low, or very low?
Okay, so we have our poll. And if we close our poll and look at the results,
we find moderate or low. Most people agree. Okay, so there weren't randomized trials. We didn't randomize people to get it right away or get it later. So it's kind of an observational study, but it's a nice subgroup analysis. There might also be some uncertainty around the baseline risk, some uncertainty about how they're going to manage the bleeding. Okay, so so now we have so what I just said, delays are not randomized but observational. There might be some uncertainty around the baseline risk. There might or might not be an increased mortality and bleeding when you doing it in the remote setting relative to waiting for Yellowknife. So now when you consider, does the bottom line change? Most of you said that 1 to 2% is benefit, but now it's a little more complicated. Now when you consider everything, thrombolysis, yes or no in the rural setting?
okay. All right, for results.
Still mostly yes. Okay. Value judgment. Okay. Now, the point of all this is, if we had just looked for direct evidence, hopeless. If we just look for the randomized trials in the urban setting, hopeless, I think. But when you piece together the different pieces of the indirect evidence, we can provide something useful to our folks in the remote setting. So that is the message here. There's always evidence. You have to think, go beyond the initial PICO, think of all the different types of indirect evidence that might bear in your decision. When you put them together, you might initially have said, sorry, we can't help you. When you put them together, you might be able to help your client quite a bit. Okay, so bottom lines. We think grade is good. The issues of quality of the evidence are complex, but grade, we think, makes them as simple as possible. It certainly is transparent and systematic, and there's very wide adoption. I would argue that the CADITH values of excellence, responsiveness, collaboration, and transparency are markedly enhanced when you distinguish between your PICO and the eligibility, when you go beyond, if you don't have great direct evidence, when you go beyond to indirect evidence. So I have used up, I believe, all but 7 minutes of my time, but I have left 7 minutes. So I am happy to take any questions, comments, or reflections on anything that we've covered in the course of this talk.
Thanks very much, Gordon. I've been watching the very active chat function and have been enjoying the actual back and forth commentary on other people's thoughts on some of the outcomes. One question is, with the last study, one of the things one of the phrases you used was value judgment. How do you articulate that value judgment to the decision makers?
Well, what you say, for instance, is our best guess is you're going to get a 1 to 2% reduction in mortality. You have to think about the logistics of doing the thrombolysis locally. You have to think about, are they going to make mistakes in diagnosis? You have to think about is there a problem with the bleeding? And are you going to lose some of that mortality benefit because they don't manage the bleeding well? But after you consider that, is it worth it? What are the downsides of giving the thrombolysis there? Resource considerations, the terror of the people giving the thrombolysis, I don't know. You have to think of what the downsides are, and you think, is that 1 to 2% mortality worth it? That's a value judgment. For just about any intervention we have, there's nothing that is free of burdens, cost, and adverse effects. We're saying, are the benefits worth the downsides? And that's a value judgment.
I think, thank you very much. And that sort of leads to the last question that I'll take on this from the chat function. How do you incorporate other kinds of data? So we've talked specifically around randomized controlled trials and observational studies. Are there other kinds of data that you can incorporate? And I'm specifically thinking around, if we talk about our Indigenous population who may not have those kinds of pieces of evidence or those kinds of study designs.
Well, I would argue they do. It's just indirect, right? So just here, we were taking all our data. None of the data that you've seen came from remote settings, and yet it turns out to be highly relevant. So I would argue that with for the indigenous, just like we've seen here with the remote, for Indigenous folks, they're not going to have direct evidence, but they may well, for many of their issues, have indirect evidence from the sort of studies that we're used to. And, you know, that's the central point. We can say, how indirect is it? But it is, as in this setting, we found very informative indirect evidence, even though nothing came from the remote settings, okay? And I would say similarly, they're not going to, similarly for the Indigenous people, they're not going to have direct evidence, but they will have indirect evidence from our study designs that might well, as in this setting, inform their decisions.
Thank you for that. And so with that, this brings us to the end of today's session. A big thank you to Dr. Guyatt and really everyone who participated in today's webinar, not only answering the polls but also in the active chat function. Certainly it was a very interactive session. A short evaluation survey will open in a new window when you exit the webinar, and please take a moment to fill it out. Judging by some of the commentary in the chat function, I think it was well received, and thank you again, Dr. Guyatt. This webinar will be posted on CADTH's YouTube channel later this week, and we'll ensure that we have Suzanne McGurn's opening remarks in there as well. And there are 2 more webinars scheduled for this series, one on February 2nd and one on February 9th, that will be talking specifically about observational studies as well. So make sure that you register. Keep an eye out on the CADTH website for information about upcoming events. There are a number of other events that are coming now in 2021. And until next time, I thank you, and please continue to wash your hands, wear a mask, and stay safe. Have a good afternoon.